My name is Martin Quinn. I'm from the out-of-hospital cardiac arrest registry, and I'm here to talk to you this morning about some of the statistics behind what we do. A lot of you have probably never heard of the out-of-hospital cardiac arrest registry, so I'm going to talk to you about its purpose. I'm going to talk to you about where most incidents occur. I'm going to cover areas such as demographics, etiology, bystander CPR, defibrillation, and survival, and how to improve survival. A brief history of the out-of-hospital cardiac arrest registry. It was set up as a result of a recommendation from the report of the Task Force on Sudden Cardiac Death in 2006, and it became government policy as a result of this. It commenced collecting data in 2007, initially in the Northwest region, and it started getting national coverage in 2012, and it's continued this till present. It's a repository for evaluation, service planning, and research into the area of out-of-hospital cardiac arrest. A brief definition of the criteria to be on the out-of-hospital cardiac arrest registry is basically all patients that suffer a witnessed or unwitnessed out-of-hospital cardiac arrest, which is confirmed and attended by the emergency services, and resuscitation attempted. From January 2012 to present, OCAR has been hosted by the HSE, Department of Public Health Medicine in the Northwest region. It's funded by the Pre-Hospital Emergency Care Council and very kindly by the National Ambulance Service. And it's got excellent academic support from NUI Galway. The purpose of the out-of-hospital cardiac arrest registry, it's to facilitate and improve survival rates from out-of-hospital cardiac arrest. And how this is done is through the establishment of the percentage of out-of-hospital cardiac arrests, survival, identify factors that contribute to survival, identify what could be done differently to improve survival rates, and provide regular feedback to service providers. At the minute, the out-of-hospital cardiac arrest registry gets its data from a variety of different sources. Most of our cases come from the National Ambulance Service via the very successful One Life programme. About a quarter of our cases come from the Dublin Fire Brigade. And we're hoping to get more input from CFR groups in the future. We get our incident log from National Ambulance Control, and we get in-hospital feedback from the acute hospitals, which are also contributing data. This next slide just shows you an out-of-hospital cardiac arrest section in a patient care report. This is both what the National Ambulance Service and the Dublin Fire Brigade use. And this slide is a copy of the CFR reports. And there's a few areas just I would like to highlight, which are very important in order for good data analysis. Is the collapse witnessed, and if so, by whom? Was there bystander CPR? What was the initial rhythm? Was it shockable? How many shocks were advised and delivered, if so? And was there ROSC at ED? I'm going to talk to you now about some of the data from 2012 to 2015. In these years, there's been 7,904 out-of-hospital cardiac arrests registered on the registry. The number is growing every year. There was 1,984 in 2014. In 2015, there was 2,219. And already in 2016, we've already surpassed that figure. This graphic breaks down each of these little dots on the map is a out-of-hospital cardiac arrest that's on the registry. And as you can see, most occur in an urban area, more than 2/3 in fact. Most cases happen at home. And as I said, most happen in an urban setting. And in urban settings, a higher proportion of patients collapse in a public place compared to an urban setting. But also from the graphics, you can see that an out-of-hospital cardiac arrest can happen anywhere: recreational sports grounds, public buildings, farms, industrial premises, workplaces, etc. Some of the demographics: most patients that suffer an out-of-hospital cardiac arrest are male. And in 2015, the ages of patients range from less than 1 to 102 years of age. The median age for females is 69 and 67 for male. Most incidences, the vast majority in fact, were from a medical etiology. Other etiologies would include trauma, that would include crush injuries, falls, road traffic collisions, etc. Asphyxia, which would be hangings, strangulations, and foreign body airway obstruction. Submersions, drownings, and drug overdose. And the median age for presumed medical etiology is 69 and 37 years for all other etiologies. This slide shows you the trend in this last few years. Bystander participated CPR. These are a cohort group of patients that are not EMS witness. And as you can see, the trend is growing from 60% up to 74% from 2012 and 2015. And this slide would show you the percentage of first shock administered before EMS arrival. It's also increased from 16% in 2014 to 18% in 2015. And this slide then would show you what that feeds into. From 2012, the overall survival rate from an out-of-hospital cardiac arrest has gone up from 5.2% to 6.7% in 2015. For every 1.5% increase in survival, you're talking about an extra 30 people that survive an out-of-hospital cardiac arrest per annum. The next slide, I'm going to talk about the Utstein comparator group. This is an internationally benchmark cohort group of patients where real progress can be made. This group includes people that are aged 18 years of age or over, from a presumed medical etiology that's bystander witnessed, and the initial rhythm is shockable. And this slide shows quite graphically the survival rate in that cohort group of people. It's gone from 21% to 27% in 2015. And these are the figures from 2015. Of that group, there was 299 people in 2015, and out of that group of people, 79 people were discharged alive from hospital. So improving survival, we need fast cardiac arrest recognition from you guys on the scene to the call taker. We need a shortest possible call response interval. We need early, good quality CPR, early defibrillation, accurate and comprehensive data gathering and analysis so we can report on what we're doing, and that translates into more lives saved. And this graph just shows you the level of coverage. Each PIN is a CFR group that's gone live, and as you can see from the slide, there's a lot of areas that's not coverage. There's no coverage. And It reminds me of the old 088 mobile phone coverage. Once you go outside the urban areas, you're in trouble. To summarise, OCAR's main purpose is to help increase survival. Most cardiac arrests occur at home in an urban setting. Most cases are male and medical. Early bystander CPR and defibrillation is the key. The survival rate is increasing, largely from a result of your own actions and contribution, and documentation is paramount. So listen, the full copy of the annual report is available here at NUI Galway, OCAR, and I have my contact details, and I just want to say a very big thank you for all coming and for inviting me here today.